This morning we have the pleasure of hearing from Dr. Deborah Doroshow. Dr. Doroshow earned her PhD in history from Yale University and her MD from Harvard University. She subsequently completed her residency in internal medicine and fellowship in hematology and oncology at Yale before joining the faculty at Mount Sinai in 2019. At Mount Sinai, she serves as an assistant professor of medicine in the Tisch Cancer Institute. She sees patients and conducts research in the early phase trials unit for patients with solid tumors enrolled in phase 1 and 2 clinical trials, and in the Center for Thoracic Oncology, focusing on patients with lung cancer. Please welcome Dr. Deborah Doroshow.
Hi, everybody. Let me share my screen with all of you. Thank you for the introduction. All right. Jim, is this visible? Excellent. Actually, hold on 1 second. Sorry, y'all. I'm realizing that my notes are not visible when I share my entire screen, so just give me 1 second. Okie doke. Thanks for your patience, all. All right. This way, at least I'll have a couple of backup notes for you in case I need them. But thank you so much to Dr. Thomas and to the department for inviting me to speak today. I'm really delighted to share this topic with you. These are my disclosures. I don't actually have any disclosures relevant to the talk itself. And I will be discussing non-FDA approved or off-label studies of FDA approved agents. So why am I talking about this topic to all of you? So as a medical oncologist and a historian of medicine, I chose this topic for 2 reasons. First, all internal medicine doctors will encounter precision oncology. Your patients will be taking targeted medications when they're admitted and when they see you in clinic. They may develop side effects from these medications requiring multidisciplinary management, and you might wonder how a targeted therapy changes their prognosis as you manage their other health issues. Second, as a historian of medicine, I think that the history of precision oncology has a lot to teach us about new discoveries in medicine. While they're often accompanied by breathless announcements in the press of their almost miraculous nature at times, most new discoveries are in fact the result of many years of development, not all of which or much of which has occurred in a non-linear fashion. And moreover, new pharmaceuticals tend to undergo what we historians call siege cycles. So in 1912, I'll take us back just for a moment, a German psychiatrist whose name was not pronounced Max Seige, it was probably Seige, but I will say Seige because I am American here, wrote perceptively about a flood of new psychotropic medications emerging on the market. As he explained, and this is translated, quote, "The first report sounded in every respect extremely favorable, but before long it became clear that these drugs caused all kinds of unpleasant or detrimental side effects. Finally, most of them found a limited special territory in which the conscientious physician uses them." And I find that this has generally been true in the history of pharmaceuticals, although the various phases can occur out of order or even simultaneously. For example, new side effects can be discovered even while enthusiasm grows, or long after an agent has been incorporated into clinical practice. But do think about this framework as we move forward today. And so the modern siege cycle, which I've illustrated here, is actually the Gartner hype cycle, which is a very similar concept used in advertising. And I do think it does a nice job of visualizing the concept of enthusiasm followed by despair or disillusionment, and then sort of reaching actually less a flat line than more a sinusoidal status in clinical practice. But again, that these phases can overlap or occur out of order. So I want to actually start by telling you about a typical patient that I might see in my Tuesday lung cancer clinic. So I meet Ms. Smith. She's a 65-year-old woman who's just been diagnosed with metastatic adenocarcinoma of the lung after having a CT to work up a chronic cough. CT-guided biopsy of an axillary lymph node showed adenocarcinoma. It was TTF1 positive as expected. And she asks, of course, what treatment will you give me? And this is a real patient that I actually saw. And unfortunately, I could not tell her the answer. I said, we need more information first. So knowing the histological subtype of her cancer, adenocarcinoma, is really important and actually will help direct our treatment in ways that histology did not actually direct treatment several decades ago. But we will actually need to do more workup. We'll need to do genomic profiling to understand any mutations that might be driving the tumor. We need to do immunohistochemical staining for PD-L1 to give us a better sense of whether or not their cancer is likely to respond to immune checkpoint inhibitor therapy. And explaining this to patients with no scientific background or low health literacy can be really tricky. I emphasize that we are not in this case, looking at germline mutations, as many patients are worried primarily that I'll find something that they've passed down to their children. I also explain that our tests are not perfect and that they give us more information, but can't perfectly predict how their cancer will respond to any given medicine. Just to give you a sense of the state of precision oncology for patients with lung cancer, this fantastic diagram from my colleague, Dr. Carty Smith, illustrates the decision tree for treating patients with metastatic non-small cell lung cancer. You can see how many targetable genes have FDA-approved treatments, and I haven't even listed them all here for lack of space. I would also include NTRK fusions, and others like HER2 are under development. So while so far only mutations in lung adenocarcinoma and not squamous cell carcinomas are targetable using small molecule medications, you can see here at the bottom right that the expression of PD-L1 also plays an important role in how we decide which patients may benefit from which treatment. An entire field of research is devoted to identifying and validating new biomarkers to help us better understand which patients will benefit from immunotherapy alone and which will need chemotherapy as well. Backing up a few years, in January 2015, President Barack Obama announced his new precision medicine initiative. In a celebrity-filled ceremony at the White House, Kareem Abdul-Jabbar was there as a famous patient with CML. Obama stated that, quote, doctors have always recognized that every patient is unique, and doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? Now, as a historian, of course, and as an oncologist, we have to take care when we talk about things like cure or oversimplifying things. But this idea of matching a treatment to a patient, even by using genetic information, this was not new in 2015. But this particular initiative gave a lot more publicity and funding to the concept, and I would argue actually further contributed to the standardization of the term precision medicine, whereas other terms like personalized medicine had previously been used a little more. So what exactly is precision oncology? Oversimplified, but precision oncology is the right drug for the right patient at the right time. When we use it, it's based on ascertaining the characteristics of an individual patient's tumor. We look at the genomic characteristics, mutations, fusions, and deletions, among other changes. We look at somatic and sometimes germline changes. Increasingly, we look at protein characteristics, both expression, overexpression, and increasingly using more advanced tools to look at protein characteristics. And these are just some examples some examples, but this is based on the belief that histology is insufficient to guide treatment and that molecular alterations result in many different kinds or subtypes of cancer. To give you a sense of where we'll go today, we've been a few different places already. We'll start by talking about the history of the one gene, one disease, one drug paradigm. We'll talk about what happens when the target we thought we were targeting isn't actually the target. We'll talk about the near inevitability of drug resistance, the promises and limitations of developing technologies, and lastly, we'll conclude with discussion of novel methods for evaluating targeted therapies using master protocols. In the late 1980s, Dennis Slayman and his colleagues at UCLA identified that a quarter of breast cancers were characterized by an amplification or overexpression of human epidermal growth factor 2, or HER2, a tyrosine kinase receptor, which activates multiple downstream signal transduction pathways to regulate cell growth. Moreover, he and others found that patients with these tumors had a poorer prognosis than those who did not. Simultaneously, multiple investigators determined that HER2 overexpression induced tumor growth, making the protein a very desirable therapeutic target. A humanized HER2 antibody, which was engineered at Genentech in San Francisco in 1992, was quickly introduced into multiple phase 1 and phase 2 clinical trials, the latter of which focused on enrolling only patients with increased HER2 expression using immunohistochemical staining. However, the definition of HER2 overexpression was inconsistent. One trial enrolled patients with 25% or more of membrane staining. A second enrolled those whose tumors had quote unquote light to strong IHC staining, and that's a quote from the published article. And a third used the now standard 2+, 3+ nomenclature to refer to weak or complete tumor cell staining in at least 10% of cells. So FDA approval was based on two pivotal studies. In these two studies, patients had HER2 2+ or 3+ tumors, which is not exactly the way that we define HER2 positivity now. With our 2+ patients, we also perform FISH, we count copies of HER2, but this was at least a standard definition for these two studies. There was a phase 2 study looking at the agent Herceptin on its own in patients who had metastatic HER2 overexpressed breast cancer. About 15% of patients responded to treatment, and the median response time was about 9 months, and median survival time was about 13 months. There was also a phase 3 randomized controlled trial looking at patients with HER2 overexpressed breast cancer who had never been treated for their metastatic disease. And patients were randomized to receive chemotherapy either with trastuzumab or Herceptin or not. And they found that patients who were in the trastuzumab arm not only had a higher response rate, but lived longer, 25 versus 20 months. However, there was also some worrisome data. 4.7% of the patients received on the trastuzumab alone study had cardiac dysfunction, typically LV dysfunction. And on the phase 3 study, the findings were even more concerning. Patients were able to get multiple different kinds of chemotherapy, but one of the most standard kinds of chemotherapy used for advanced breast cancer or even early stage breast cancer are anthracycline drugs, which are known to be cardiotoxic. And so 8% of patients in the chemo alone arm who had gotten anthracycline chemo had cardiac dysfunction, but 27% of patients in the combination arm had cardiac dysfunction. So again, this is sort of the convergence of the both enthusiasm about this new targeted drug, but also the realization that it may have some very concerning toxicities. Nevertheless, trastuzumab was hailed by the popular press as, quote, ushering in a new era of cancer treatment that attempts to target the very flawed genetic mechanisms that cause the disease. The Washington Post described how one patient's impending death was dramatically reversed by Herceptin, which shrunk her liver metastases, quote, to mere dots, and showed, quote, how 20 years of basic cancer research are beginning to pay off for patients, end quote. Yet the popular press also reminded readers that although trastuzumab appeared to be a wonder drug, it was not a cure. And Time magazine, despite this very dramatic cover, and I'll show you multiple dramatic Time magazine covers, does say at the bottom, how to tell the hype from the hope. While trastuzumab itself did not dramatically improve outcomes as a single agent, it has become a critical life-prolonging adjunct to chemotherapy in the metastatic, neoadjuvant or before surgery, and adjuvant or after surgery settings. The identification of HER2 as a valuable therapeutic target spurred additional work, resulting in the development of trastuzumab and emtansine, a novel antibody drug conjugate targeting HER2, and pertuzumab, a monoclonal antibody binding a different epitope of HER2. Perhaps most intriguingly, trastuzumab has changed the natural history of patients with HER2-positive breast cancer. Whereas Sleeman and colleagues initially identified HER2 overexpression as a poor prognostic marker, patients who are treated with HER2-directed therapies may no longer be at a survival disadvantage. Now, HER2 overexpression has become a predictive biomarker, indicative of a subset of patients likely to respond to HER2-directed therapy. And I'm showing here the overall survival Kaplan-Meier curve from the Cleopatra study, which showed that adding pertuzumab to chemotherapy and trastuzumab in the metastatic setting improved overall survival from 40 to 56 months, a long cry from the 25 months I showed you with the early chemo trastuzumab trials. So really great advances have been made in this area. 3 years after trastuzumab was approved by the FDA, another landmark drug was introduced, imatinib, for the treatment of chronic myeloid leukemia, or CML. The press similarly described the drug as a miraculous magic bullet, proclaiming that, quote, the dream of a pill that can treat cancer with almost no side effects became a reality, end quote, and referring to targeted drugs as smart bombs that did not induce the collateral damage seen with cytotoxic chemotherapy. Patients who had participated in clinical trials of the drug spread the news in online chat rooms before trial results had even been published. This enthusiasm was understandable. And so here you can see a couple of headlines: cancer drug approved quickly, Gleevec dramatically effective against a type of leukemia. That's the Post. Larry Altman, the New York Times' medical writer, wrote, cancer doctors see new era of optimism. And again, another sensationalist cover from Time magazine, there is new ammunition in the war against cancer. These are the bullets. So again, really using this language, which has been used for over a century, of the idea of the magic bullet, one drug that will really solve a given disease in a targeted fashion. This enthusiasm was understandable, and these are images from the original New England Journal paper of the phase 1 study of imatinib, which was a small molecule inhibitor of the BCR-ABL tyrosine kinase. And they first of all found that there was no maximum tolerated dose. They got up to their maximum dose with no severe side effects. 53 of 54 patients on the left achieved a complete hematologic response, defined below, and 29 had either a major or minor cytogenetic response. I will note here that as the technology has changed, they were specifically looking at cytogenetics. They would look at 20 cells in metaphase rather than looking at transcripts as we do today to get an even more fine-tooth reading. However, these results were so impressive, and based on these results, as well as the results of 3 phase 2 studies, imatinib was actually granted accelerated approval by the FDA in 2001. The 72 days required for FDA review was the fastest agency approval in the history of anti-cancer drug development. But despite the perception of a sudden breakthrough, I think the history of imatinib really illustrates the extensive, lengthy research that went into identifying the molecular target and crafting a drug to engage it. This didn't just appear out of nowhere 3 years after Herceptin as the next bullet. So I just want to take you through a little bit about how we got from identifying CML to Gleevec and how it was not a sudden process. So In 1845, CML was actually first described as a disease entity. About a little over a century later, the quote unquote minute or small chromosome present in the blood of 7 patients with the disease was described. And in the early 1970s, that minute chromosome was identified as chromosome 22. Rowley discovered that the minute chromosome was the result of a balanced translocation with chromosome 9. And in the 1970s and 1980s, which was especially the 1970s, a boom time of research directed at oncogenes, which had actually been derived from a lot of research on oncogenic viruses, was part of this work actually identified c-Abl as an oncogene, which had been the result of a translocation from 9q to the breakpoint cluster region, or BCR, now you know where it comes from, of 22q minus in patients with CML. In the mid-1980s, it was discovered that the resulting mRNA transcript was a tyrosine kinase in itself. And in 1990, Heisterkamp and colleagues identified BCR-ABL as both necessary and sufficient to induce CML. High throughput screens were performed in the early 1990s of hundreds of agents discovered from natural substances all around the world and modified chemicals, and ultimately identified the 2 phenylamminopyrimidines as promising inhibitors. And in 1996, Brian Drucker and his colleagues published the first in vitro and in vivo data on imatinib. Now, a couple things. I typically, as a historian, do not take people through these timelines of first A happened, and then B happened, and then C happened. And usually A, B, and C have all been discovered by white men. And the idea being that, you know, this discovery followed naturally upon the previous discovery, and so on until we reach some sort of ultimate truth. In fact, I actually want to point out that Rowley, who identified the balanced translocation with chromosome 9, was a woman. But more importantly, that this research was not some sort of very neat, organized progression. What I really want to point out here is that Gleevec did not emerge instantaneously. In fact, research identifying BCR-ABL as the causative oncogene and as a tyrosine kinase contributing to CML, and in fact, both necessary and sufficient for CML, had really been the result of many, many decades of research. Oops, sorry. So by 1996, Brian Drucker and his colleagues, as I mentioned, had published this in vitro and in vivo data, demonstrating that one such agent, STI-571, or imatinib, potently inhibited the BCR-ABL tyrosine kinase and killed CML cells. 5 years later, STI-571 had been approved by the FDA. And so again, while the development of imatinib had itself been brisk, the identification of this therapeutic target was an effort spanning many, many decades. And certainly this breathless media coverage overlooked that aspect. The history of imatinib has also been unusual in other ways, one of which is the durability of responses produced by the drug and its second and third line agents. Resistance to therapy does develop and has spurred the introduction of these later line agents. Still, patients with CML who are treated with these inhibitors can expect to live very long, near normal lifespans. The introduction of these drugs, 5 of which are now FDA approved, has altered the natural history of CML to the extent that the field is now exploring the theory and the potential of discontinuing therapy for patients whose disease is very well controlled. But there have certainly been some major bumps in the road. Some patients just can't tolerate these drugs, and others develop resistance. Ponatinib, a next generation TKI, which is the only drug that targets a specific T315I resistance mutation, was actually briefly pulled off the market after FDA approval, given the occurrence of fatal clotting events like strokes, myocardial infarctions, and heart failure, and then was put back on the market with a black box warning. While the importance of identifying a molecular target prior to developing a relevant therapy might appear very obvious, in many prominent cases, a target has been identified and refined during the course of drug development. This is exactly what happened during the development of agents targeting the epidermal growth factor receptor, or EGFR, for patients with lung cancer. Initial work on EGFR, which was known to play an important role in modulating proliferative cell signaling, was based on its overexpression in multiple tumor types, including non-small cell lung cancer. As one review stated in 2011, quote, EGFR is expressed in a wide range of solid tumors, including 40 to 80% of non-small cell lung cancers. And it seems that high levels of EGFR expression are associated with disease progression and poor prognosis, providing a strong rationale for assessing EGFR inhibitors in various solid tumors, including non-small cell lung cancer. Surprisingly, though, phase 1 trials of the EGFR tyrosine kinase inhibitor gefitinib produced few clinical responses. The 2 phase 2 studies of gefitinib in non-small cell lung cancer patients were slightly more promising, with response rates of between 9 and 19%. However, a retrospective analysis of tumor specimens collected from patients on these trials, and this is why we often do biopsies of patients on trials to better understand why certain patients respond and why others don't. So looking at these biopsy specimens found that there was absolutely no relationship between expression of EGFR as determined by immunohistochemistry and clinical response to the drug. Still, based on the results of these studies, gefitinib was actually granted accelerated approval by the FDA in 2003. However, the FDA review interestingly noted the negative unpublished results of 2 large phase 3 studies that had failed to show clinical benefit of the drug in combination with chemotherapy for patients with advanced non-small cell lung cancer. Several groups of investigators sought to further categorize and characterize responders by analyzing tumor specimens for patients who had been entered on these phase 2 studies, as well as those treated on expanded access programs. They identified several subgroups of patients with higher response rates: Japanese patients compared to non-Japanese patients, women, never smokers, and patients with adenocarcinoma histologies. Simultaneously, several groups of investigators sequenced the EGFR gene in patients who had been treated with gefitinib on clinical trials. They identified, and you can see here, these publications were really simultaneous, and both came out of Harvard, although on different sides of the city, one at MGH and one at Dana-Farber. And these investigators identified mutations in the EGFR tyrosine kinase domain. On the right, these are the mutations in this catalytic kinase domain pictured here in yellow, with some of the most common mutations identified in red. And these mutations were present in almost all tumors from patients who had responded to the drug. And they did not find these mutations in patients who had not had responses with the drug. So this really established mutated EGFR, not overexpressed EGFR, as the molecular target for gefitinib. And so while EGFR targeted therapies have become a success story in lung cancer, their evolving history is actually more representative of targeted therapies in some ways than that of imatinib or Gleevec, in that resistance to treatment is inevitable. Over the last 10 years, studies have focused on the development of second and third generation inhibitors, which specifically target mechanisms of resistance, particularly the T790M mutation, which is typically found in patients who have progressed after a first-line inhibitor, like gefitinib or erlotinib. And I couldn't resist a good Star Trek joke, but resistance is not actually futile, resistance is inevitable. So what I wanted to show here is that really we saw here resistance mechanisms to first generation EGFR tyrosine kinase inhibitors. And you can see here that 60% of patients who developed resistance did so by getting this T790M mutation in exon 21. So then the natural next step was to develop a drug that could hit that resistance mutation. That was osimertinib. In fact, I also want to point out that in the interest of making history a little bit more messy, I recall that there was another drug that actually got to phase 3 testing called ruxolitinib, and we thought that was going to be the next big drug. It actually completely flamed out. So just to show that whenever we think we know what's going to happen, we are wrong. And so having that humility is really important. And so osimertinib, a third generation TKI, was studied specifically in patients who had developed this resistance mutation. And as you can see by this beautiful waterfall plot, 62% of patients who got this drug had a response, which is defined in our oncology world as having a 30% shrinkage in the target lesions that are being followed. You can see here that the vast majority of patients had their cancer shrink at least somewhat. So this was really a remarkable finding. So interestingly, the next step was to ask, well, what happens if we give this nifty drug up front? And interestingly, patients, first of all, survive with a median survival of 38.6 months when they received this novel third generation inhibitor. It's not quite novel anymore. We've been using it for a few years, but this was very exciting data. It was really the first data to show an overall survival benefit of one of these targeted agents in lung cancer, although the upper limit of the hazard ratio as depicted in the supplemental data is actually 0.997, so it wasn't quite 1. But this was actually very impressive data. Interestingly though, patients who start on this agent don't develop that T790M mutation. And so we actually have prevented the development of a particular resistance mutation and changed the natural history of this particular subtype of non-small cell lung cancer. And I think this is a really helpful diagram. So on the left, you see resistance mechanisms. Actually, I want to show on the right, resistance mechanisms to first line osimertinib. So again, T790M is a huge problem. And then to, sorry, I meant second line. I'm getting a little flustered. Going back to the left side, second line osimertinib, meaning the patient has received Tarceva or gefitinib, often develop T790M, and then they may receive osimertinib. However, resistance is inevitable and patients develop a panoply of mutations. For patients on the right who've received first line osimertinib, which is now our standard of care, the panoply of resistance mutations is very different. It is not identical. So that even as we work to develop these new drugs that will target resistance mutations, as we move them forward and start using them earlier, we actually change the natural history of the resistance mutations that develop. Sometimes it feels like you're just always one step behind. And it's hard because with every advance, we're very excited to have new medications with which to treat patients, but we also know that resistance will be inevitable in the vast majority of cases. So in order to detect molecular alterations that can be targeted, we need reliable, efficient, and affordable technology. The early work on trastuzumab was limited to immunohistochemical staining, whereas fluorescent in situ hybridization, or FISH, as I mentioned previously, is now a routine component of HER2 testing for tumor samples with equivocal or 2+ staining, and has really changed the definition of what we count as a HER2 positive tumor. In the 2000s and early 2010s, molecular alterations could be detected using either immunohistochemical evaluations of protein expression or PCR-based evaluations of mutational hotspots, which could miss uncommon alterations. So when I started my training, I know I may look like I'm in high school, but it was actually a few years ago. I did a PhD, and when I started my training, we would test specifically for only a few genes like EGFR and ALK that we knew would be targetable for non-small cell lung cancer. But especially when we use these hotspot testing mechanisms, we would only look for the most common mutations. And we now know, for example, that there are a very wide variety of mutations in EGFR. So this was not a perfect mechanism, but what can we do now? In 2020, have we solved everything? Of course not. In 2020, though, a patient's tumor may undergo high throughput, massively parallel DNA and RNA sequencing, which we often refer to using the term next generation sequencing, or NGS, over a matter of 2 or 3 weeks to identify potential therapeutic targets. These analyses may look at several hundred genes, and they are regularly performed on the tumors of patients treated not only at tertiary cancer centers, but in the community as well. And the latter was really made more accessible due to the fairly recent announcement from the Centers for Medicare and Medicaid Services that Medicare would actually cover next generation tumor profiling for patients with advanced cancers. And this was a big win. More comprehensive analyses using whole genome or whole exome sequencing, proteomic analyses, and studies of DNA methylation patterns, just to name a few, are feasible, but they've not really been adopted into standard clinical practice yet, and they're expensive with long turnaround times. More recently, analyses of circulating tumor cells and circulating tumor DNA, or ctDNA, have been investigated as a way to dynamically and non-invasively assess tumor burden and to help evaluate the changing genomic landscape of a tumor throughout a patient's treatment, which can help us better understand the mechanisms of a specific patient's drug resistance. So for example, when I treat a patient with osimertinib and their disease progresses after a time, we often will send a liquid biopsy to resequence EGFR and look for resistance mutations both in EGFR and in other genes that may be causing that resistance. That information can give us more information with which we can treat patients using both approved drugs and drugs that are still under clinical investigation. Still, again, this may seem like an orderly progression. We have gone from the point where we could do relatively limited analyses to the point where we can do relatively comprehensive analyses. However, this is, again, not a stepwise progression toward perfection or ultimate knowledge. There are many drawbacks. I just want to point out a few. So for the vast majority of patients, when we send out a next generation sequencing panel, we get a lot of information. Very little of that information is actionable. For example, the vast majority of patients with cancer have mutations in genes like KRAS, which until very recently was not targetable in most cases, and TP53, which to date has really not been targetable, but has been under active study for decades. We get information about VUSs, or variants of unknown significance, that we really don't know what to do with. These variants haven't been studied. So we may get a lot of information, but we may not have information for which that we can use to treat patients either with an FDA-approved drug or a drug that's under active clinical investigation. Driver versus passenger mutations. So just because you see a mutation in a patient's tumor doesn't mean it's actually running, it doesn't actually mean that it's driving the tumor. It's not driving the bus. So you may have mutations that are just there, but blocking those genes, blocking those proteins using targeted medications may not actually affect the cancer. And we're not that good at understanding, if you get a lot of interesting results, how do you sort through those results and decide which one is actually the most important? We also struggle with intratumoral heterogeneity. We know that even within a single tumor, there is a lot of heterogeneity when it comes to the genomics of the tumor, protein expression, epigenomics, methylation patterns, post-translational changes. We know that metastases and primary tumors may often look very different. Patients with breast cancer who have hormone-positive breast cancer may develop triple-negative metastatic disease. So we really struggle with this question of intratumoral heterogeneity. How representative is our sample? And there also is temporal heterogeneity, as I mentioned. So we may look at a patient's biopsy from 6 years ago. Well, that may have something to do with what their cancer is doing now, but it may not. And one particular area that we are struggling with right now is that we're really doing this PD-L1 testing, which is an immunohistochemical stain, more and more to understand whether patients with certain cancers might benefit from immune checkpoint inhibitors. It turns out that a patient's tumor and its PD-L1 stain is very dynamic. And so it may be completely irrelevant if we look at a specimen from a surgery that was a few years ago. So despite the fact that we're essentially getting more and more information, we don't always have information that we can use, and this information may not be always reliable. However, I think while we are detecting more and more molecular alterations, we are starting to develop some novel clinical trial designs, many of which are still early in development, to test some of these targeted agents. So I'd like to tell you a little bit about a few of these designs and how they work. So master protocols, which enable us to evaluate patients with multiple tumor histologies and or multiple kinds of molecular alterations, are both powerful and complex frameworks that we use to really test a variety of hypotheses simultaneously. By grouping tumors by molecular alteration, they move oncology toward a less histology-based framework to really more of a molecularly based diagnostic and clinical framework. And classically, we've really grouped these master protocols into two categories: basket studies, which are illustrated on the right. And these are really studies which seek to treat patients with multiple different kinds of cancer whose tumors share the same molecular alteration, like the same gene, same mutation, for example. And then umbrella studies, which you see on the left, which really assign patients with one tumor type to one of several therapies based on profiling data. Basket studies can play a critical role in promoting a histology agnostic approach to treating cancer. 2 phase 2 studies of pembrolizumab, an anti-PD-1 antibody, in patients with mismatch repair deficient tumors showed that the drug was efficacious across many, many different kinds of cancers. On the left, you can see that every color represents a different kind of cancer, and all of those lines going below the x-axis represent tumors shrinking. And these studies actually led to the first tissue agnostic FDA approval of a drug. The following year, a really exciting phase 1/2 study of larotrectinib, an NTRK inhibitor, in tumors that had TRK fusions led to the second FDA approval of in a histology agnostic fashion in 2018. This was particularly exciting because this study included multiple very rare tumor types and included both pediatric and adult patients. But basket trials are not always unmitigated successes, and just because a cancer has a certain mutation doesn't mean it will act the same as a different kind of cancer with the same mutation. This is a study of vemurafenib in patients with advanced BRAF V600 mutated malignancies other than melanoma, in which the drug had already been developed. And they found that 42% of patients with BRAF mutant non-small cell lung cancer and 29% of patients with BRAF mutant anaplastic thyroid cancer, particularly devastating tumor type, actually responded to this drug. And this led to FDA approvals for this drug in those 2 settings. But few or no responses were observed in multiple other tumor types. You can see on the right that they had a smattering of patients with other tumor types. They had 1 out of 6 responses of patients with glioma, for example. So this was not an unmitigated success by any means. What about umbrella trials? To date, these have primarily served as exploratory signal-seeking studies. They often operate using adaptive designs in which new arms can be added or subtracted based on new evidence or removed based on lack of response. And this is a diagram of one such pretty well-known umbrella trial called LungMap, which separates patients with squamous non-small cell lung cancer into treatment groups, really based on the mutations found in their tumors. And as you can see on the right, again, we don't always find patients with one of the mutations we're looking for. So there are several arms that patients can go into if they don't have a mutation. And to date, most of the arms of this study have been therapeutic failures. We have not found exciting targetable mutations so far for squamous lung cancer. On the other hand, this study is in some ways a success because patients were screened and profiled with molecular sequencing done in real time to assign them to trials, sort of showing proof of concept that we can do these types of trials. But we have a long way to go. The terms basket trial and umbrella trial are useful heuristics, but they really may not adequately describe all large platform precision oncology trials. The ongoing, almost, I believe, completely accrued now, NCI-MATCH study, which stands for Molecular Analysis for Therapy Choice, uses on-study biopsies to assign patients with any histology to a broad range of therapies based on their tumor molecular alterations. So MATCH is not either, it's not really an umbrella study or a basket study because there are many different kinds of patients with a variety of tumor types and a variety of molecular alterations. But these hybrid platform studies really enable us to evaluate a number of different hypotheses at the same time. MATCH was also really exciting because this is actually part of a poster that was created to appeal to patients, and I think does a very nice job of explaining a complicated concept in a comprehensible way. And I think one of the great successes of MATCH, which accrued much more quickly than the investigators had planned, was that the majority of accruals actually came from community sites, not from large tertiary cancer centers. Master protocols like these are very challenging. They're time consuming, they require significant coordination among multiple stakeholders. Many different pharmaceutical companies may be involved. Try getting 20 different pharma companies to collaborate, or even 2 or 3. It's very difficult. Patient advocacy groups are often involved. The NIH, NCI is often involved. Many different institutions, all of whom have their own intellectual property policies. They can be very costly. And so due to these complexities, master protocols rarely lead to new FDA indications for pharmaceutical companies, which in some ways is a disincentive for them. And they create significant work for regulatory officials, statisticians who must design these studies, and institutional review boards faced with numerous amendments coming very quickly. Despite these challenges, I really think that master protocols offer many opportunities for both patients and investigators. They enable patients with rare cancers to participate more readily in clinical trials and may lead to more therapeutic options. They efficiently group patients with multiple tumor types, they're adaptable, and they enable large collaborations across institutions, companies, and different advocacy groups. They can also provide access to laboratories performing validated assessments of specific treatment-defining molecular alterations in patients' tumors. Once established, the infrastructure for these trials can speed the screening of new therapeutic agents across patients with a wide variety of both common and rare malignancies. So where do we go from here? Well, newer platform studies are looking at combinations of drugs because we're really starting to see again that with individual single agents, we almost inevitably get resistance. So the idea being that with combinations, we can try to head off some of that resistance. We're using immunological biomarkers increasingly to assign patients treatments, especially immune therapies. But we still need to really better leverage the data that's discovered in the lab to decide which agents and which combinations to study in which populations. We have a problem now where we have too many trials and not enough patients. In fact, fewer than 5% of American adults participate who have cancer participate in a clinical trial, yet the number of clinical trials is blossoming. So we really need to, of course, do a better job trying to engage patients and accrue them to trials and explain the real opportunity that exists for participation in clinical trials, but also we have to be smarter about choosing which combinations to study. It's critical that we use pharmacodynamics, using patient biopsies, to understand if a drug is hitting its target and why some patients respond while others don't. If they hadn't looked at the biopsies of the patients on those EGFR studies, they wouldn't have realized that overexpression had nothing to do with whether or not a patient benefited from the drug. So I think while some critics have tried to argue that precision oncology is either a good thing or a bad thing, I think that argument is sort of honestly not very useful. I think precision oncology is here to stay. It's not a question of whether or not the tactic works, but how to make it work best. And of course, access. We know that patients who are treated in the community are less likely to have next generation sequencing performed on their cancers. And for patients with lung cancer, where we have so many effective targeted agents, it's really heartbreaking. And so there's a lot of education that needs to go into making sure that all providers order these tests and can utilize the results of the tests. Again, the reports can often be 20 pages long and difficult to comprehend. So we think that's really important too. So I really appreciate the opportunity to speak today. I appreciate the support of the TCI leadership, the Early Phase Trials Unit, the Center for Thoracic Oncology, the Hematology Oncology Fellowship, my family. This talk today was in part based on an article I wrote with my father, who is also a medical oncologist, and of course, our patients who keep us going every day. Thanks very much.
Great, thank you, Dr. Doroshow. I think, so please, if you have questions, you can put them in the chat. And we can start off. Dr. Greenberg has a question, Debbie. Oops. And it's, can a tumor-specific antibody be conjugated with something that will kill the cancer cells, including cells that do not have antibody attached? Example, a radioactive conjugate that could kill nearby cancer cells that do to themselves have the antibody attached.
Okay, I'm going to do my best to answer that question. I'm not 100% sure I understand it. But basically, with the development of these drugs called antibody drug conjugates, you essentially have an antibody that targets something on the cancer cell that's not present in normal cells, or at least it's present in much higher concentrations on the cancer cell than on regular cells. And it's attached by a linker that is not permanent to a chemotherapy bomb, typically. And so we have several of these drugs. We have actually a very successful one. Trastuzumab deruxtecan was just approved for patients with HER2 overexpressed breast cancer. And so the idea is that this bomb is really delivered just to the cancer cells, sparing the normal cells. Of course, there is no perfect bomb, right? I hope I have disabused the idea of the magic bullet in oncology. I think that, we do see what we call off-target effects. These antibody drug conjugates absolutely have caused side effects on non-cancer cells and make people feel lousy. But we also talk about something that we call a bystander effect that can be seen either with an antibody drug conjugate or just an antibody like HER2, where we can actually have a response against localized cells that do not express the target. Sometimes, for example, with antibody drug conjugates, the linker may come apart, and so the chemotherapy may be floating around in the area and affect bystander cells. So none of these targeted bombs are perfect.
Thanks, Debbie. Andrew Dunn has a question for us. Thanks for the great talk. Besides the hopeful impact on mortality, do you feel that precision oncology will eventually be cost savings by reducing ineffective tests and hospitalizations, or expensive? Important given the need for access to care.
Thank you for that question. One of my areas of research is financial toxicity. As many of the physicians I work with, and especially the nurses and nurse practitioners we work with who perform a lot of the prior authorizations, can tell you these drugs are very, very expensive. Most of them are not generic yet. We do have a biosimilar for Herceptin, again, because it was one of the first ones out there. But for example, a new study just showed that osimertinib, that third generation EGFR inhibitor for patients with lung cancer, really massively decreases the chance that, or prolongs the period before a patient's cancer returns after they've had surgery, if they have this mutation. And one major critique that's been brought up is, well, this study has not definitively shown, at least yet, that the drug improves survival. And this is essentially going to create an enormous new market for this drug, which of course is very beneficial to the company. But this drug is very, very expensive, and we really have no price controls. We do have patient assistance programs, but we can't provide patient assistance programs to all of the new patients who are going to need this drug now. So I think it's an enormous concern. I do think that the cost of next generation sequencing will continue to decrease over time. Of course, now we will soon start to do whole exome and whole genome sequencing, which will introduce, at the more tests we do, the more costly they are. But I do think that NGS is certainly, the cost of that will decrease as we move forward. But I am very worried about the cost of these agents. On the other hand, they often, these are not benign agents. Some of them are very well tolerated. Others can cause very serious side effects that can necessitate hospital admission. But I think, if you ask patients who are on these drugs, I will tell you that many of my patients on these drugs really are very happy to be taking a pill for their cancer. Chemotherapy is still really laden with stigma. And that's something I try to reduce in my clinic. But being on a pill is very meaningful for a lot of patients. And that's something that I wouldn't overlook as well. But and the fact is that with many of these drugs, patients are living a lot longer. So whether or not that's cost effective, I do know there is literature on this, and that's not something I'm an expert on. But I will tell you, from a clinician's point of view, I worry very much about patients who are not able to access these medicines, even though they are FDA approved. But we have to jump through a lot of hoops. And even when they are approved by insurance, co-pays can be absolutely horrendous. Sorry, I don't mean to be a Debbie Downer.
We can go with one more question from Dr. Michelle Kim. And she asks, can you tell us more about the NCI-MATCH clinical trials? Were the same genetic abnormalities found across different cancers? And then did patients who received treatment targeted to these genetic changes respond similarly, even if they had different cancers?
Great question. Thank you so much. So indeed, the idea of the trial was that we know that patients across many, many different types of cancer have the same mutations. So indeed, many patients, and this was how they were enrolled to the trial. So each arm of the trial, and they actually, they were lettered A to Z, but then there were many, many, many arms. Actually, I think there were some 40 plus arms, each symbolizing one specific mutation for which one drug was provided. Either an FDA approved drug that was being used in a new way, or an investigational drug. And so indeed, they certainly found these patients all across the country, from academic centers to community locations. And in some cases, they absolutely found that patients responded similarly, and many arms were absolute failures, and they did not find that patients responded. So I think there was sort of an oversimplistic dream, several decades ago, that all patients, that we would, people would talk about the fact that we're no longer going to have a lung cancer clinic or a GI cancers clinic. We'll have a BRAF clinic and a TP53 and an EGFR clinic. And I think that's also oversimplification, because we know from studies like this that histology does matter and context does matter. A lot of people are looking, for example, at the immunologic tumor microenvironment, trying to understand how that impacts response, or looking even at the tumor microbiome. So that, I think, thinking that one mutation just completely unites all these patients is oversimplistic. But as we have seen in the case of some mutations, these drugs can absolutely work across tumor types.
Great. Thank you, Debbie. Thank you, Dr. Doroshow. Really, very informative talk. Lots of, I know we've been planning having you to give this talk since before the pandemic started. So happy we finally were able to get a time for you. So thank you very much, and have a great day, everybody. Enjoy the day.
Thank you
Take
so
it
much.
easy. See y'all. See you, Debbie.